Bonsoir et
Ladies
bienvenue
and gentlemen, good day.
au webinaire
Welcome to this webinar,
qui fait partie des séries de webinaires
which is part of our ongoing webinars that we've been preparing for several weeks to share experience for the implementation of the Impact 2 project in the Zender, Bosso, and Tawa regions. And today,
portera sur
we will focus
les thèmes
on
atteindre les adolescents
reaching married adolescents
les services de planification
with family planning services in Niger.
animés par
And today will be presented by Osseni Akim,
programme au niveau de
who is our technical manager for Pathfinder.
Akim est en ligne.
Akim is present. He is online.
Je pense qu'on va faire économie des protocoles.
So let's not waste any time and move on directly to the presentation. We apologize for the delay, and we also apologize for last time and due to our internet connection issues. So let's move on and let's give the floor to Assani Osseni Akim, who is going to move on directly into the presentation. Of course, let me remind you that if you have any questions, please add them into the chat. And then we will move on to the question and answer session at the end of the presentation. Akim, welcome to you. You have the floor. Thank you so much. Thank you so much, Dr. Assemi, for this presentation, for this introduction. Ladies and gentlemen, good day to you wherever you are in the world. In the name of the Impact 2 project, it is my pleasure to share with you this series on mobilizing services. And today's the first part, which is reaching married adolescents with family planning services in Niger. Next slide. Here is my presentation plan, which will be divided into 3 different points after the presentation of the context of the implementation. I will present you with the information on research action RMA, which consists on the overview, the intervention, the implementation schedule, the overview of data collection, and key research findings. Then the third point will focus on the RMA model, which will give you the model overview, the implementation schedule, the scaling up, the area of intervention, the implementation process, some results, and of course, the potential challenges. Next slide. So in terms of context, married adolescent girls in Niger regularly face serious barriers that prevent them from accessing the services they actually need to enjoy their rights to a healthy sexual and reproductive life. Sexual activity and reproduction usually occur at an early stage in the context of marriage. And even though human rights standards set at age 18, the minimal legal age for marriage, in Niger, the median age of first marriage is 15.7 years old, and 76% of Nigerian girls are married by age 18. And it is important to note that it is the highest rate of early marriage in the world. Once they are married, those girls are pressured to have children right away. And the median age of first intercourse is 15.9 years old, which explains why the country has one of the highest early pregnancy rates in the world. Social norms, additionally, encourage early and frequent pregnancies, which put married girls and their offspring at risk. Modern contraceptives have, to prevent early pregnancies, have the potential to prevent those closed space pregnancies, but only 5.9% of married adolescents 15 to 19 to use modern methods of contraception. And within this context, Pathfinder has implemented the following project, Reaching the Married Teenager, which that we will call RMA, which is integrated in the research project Impact 2 in Niger. The main expected results or the goals are to strengthen family planning services delivery at the facility and community levels in different regions of Niger, but it's also to share evidence, information, and aid data to show the effectiveness and the cost of HRHR interventions with the health department and other stakeholders. Then the objective is to develop community-based intervention based on the need to address social and gender norms, as well as individual attitudes and behaviors to increase family planning use among married adolescents. So it is a critical opportunity to learn what our interventions are most effective and to identify a final RMA model for scaling. So under its original initial form, the primary intervention is divided into two main components. So the first one, which can be described as home visits to teenagers, to adolescents and their husbands, so men and women, girls, boys and girls. And the objective is to provide information and provide advice on health issues. We also set up different visits to provide chats, fireside chats, to talk about health, to talk about puberty, contraception, gender, and violence, but also discuss their hopes, their dreams, and challenges. And those discussions with husbands, with mentors, they implemented group discussions to encourage more equitable gender norms, support more contraceptive use, positive health-seeking behavior, and also increase communication within the couple. Those little group discussions were facilitated once a month by a mentor of the same sex. So that was those were the primary interventions, but we also implement secondary interventions that include the gatekeepers, the religious leaders, the parents, the head of the village. And the idea is to create an environment which is conducive to the use of those methods. Those dialogues were facilitated once a month and facilitated by 2 community leaders. All these RMA interventions are not led the same way in all different districts. They were scattered in between all 3 districts. So for example, in Loga, the Loga district. Next slide, please. So in Loga, we observe mostly home visits. In Doutchi, there were more small group discussions. And in Dosso, all 3, home visits, small group discussions. We also noticed that the community dialogue is a cross-cutting discussion that happened in all 3 districts to facilitate this environment. So after these 3 types of intervention, there's a fourth type of intervention. If you can come back to the presentation. Thank you so much. So after these 3 types of intervention, there's a fourth one, which we call the control prevention, which includes all 4 villages where there were no interventions in each of those villages. And so we would compare notes compared to all the different types of interventions. So what is the RMA implementation schedule? So it started in 2016 with an initial survey in July. And after the survey, the initial model was deployed in all 3 districts with the support of a partner, a local NGO partner, which was in charge to accompany during the visits and observe, and which organized with Pathfinder monthly meetings for community health workers. This intervention was led up until August 2018, and after which another survey was deployed. And so after the survey, a few elements were altered and modified in terms of intervention. So Pathfinder suppressed or ended the collaboration with the NGO, and a few selected villages no longer received the support of Pathfinder after the survey. So half of those villages kept receiving informal support and the others did not. And after that, the intervention continued and ended in November 2019. After the final survey at that time, the final results were analyzed and a new model was created and used to scale up starting 2020. Let's look now at the overview of data collection. From the inception of the study, this study focused on the 4 different methods, different arms, which are cluster randomized study within each district. So 3 arms with different intervention packages and 1 control arm, which is where randomly selected different villages in each district. The first one was Loga, the second one was Doutchi, and the third one was Dosso, which was combined. So between the midterm survey and the final survey, each intervention component, after 1 year of full RMA program support, those villages were randomized to receive either continued yet reduced the support of the RMA program, and they call here support plus, and no RMA support whatsoever. And you can see here it's support minus. Let's look at the main results of the RMA analysis. Those will be represented as those key questions for scaling up. So first of all, the effect of the intervention. What is the most effective approach or intervention to increase the current use of these contraceptive or this use? Or how long, what is the duration of exposure? How long do you need to implement the intervention? The profitability, but also the minimum area of intervention. What is the minimum intervention area to see changes in the current use of family planning? And what are the effects of beyond the current use of family planning? Next slide. So let's talk about the effects of the intervention. So compared to each control arm, each intervention experienced an additional increase in family planning use.
parcours comparativement à l'enquête finale. Et on constate aussi que par rapport
we noted
chaque bras
that
d'intervention,
compared to the control arm, there has been an increase of the use of family planning methods.
en résumé,
To summarize,
on a
from
constaté
the initial, so the midterm survey, we noticed improvement, especially in Arm 1, home visits only, and Arm 3, which combined group sessions
dans l'utilisation
and home visit. We noticed significant increases of the use of contraceptive methods in all three arms. We noticed that in Arm 1,
PF, qui est passé de
although there was a
22% à 10%,
slight reduction of use of family planning from 22 to 17%, in Arm 2, an increase of this use from 11 to 21, and there's basically no change in Arm 3 of the use of family planning methods. Let's now talk about the duration of
de
exposure.
base de l'enquête à mi-parcours à l'enquête finale,
We see that from the initial survey to final survey, a small decrease use of family planning
le groupe où le soutien s'est
for
arrêté,
both
avec respectivement 18% et 17%. Slide.
Support
Dans le district sanitaire de Doutchi, le bras 2, nous voyons que l'utilisation actuelle de la PF, entre l'enquête à mi-parcours et l'enquête finale, cette utilisation a régressé, passant de 11% à 8%, alors que dans le groupe où on a arrêté le soutien, cette utilisation s'est augmentée. Et cette augmentation pourrait s'expliquer par le fait que les bras, les villages du district sanitaire de Doutchi où on a arrêté l'intervention ont assimilé cela comme une concurrence qui se joue entre eux et les autres villages, et donc les relais se sont mobilisés autour de leur chef de village pour redoubler d'efforts afin que voilà, leur performance soit à la hauteur des attentes du projet. Et c'est cela qui expliquerait probablement cette augmentation de l'utilisation actuelle de la PF dans le rang des populations des villages où on a arrêté le soutien après l'enquête à mi-parcours. Slide. Dans l'approche combinée, nous constatons que l'utilisation actuelle de la PF a augmenté dans le groupe.
One moment, Vanessa and Akim, it seems like, Vanessa, you're currently on the French channel, but interpreting.
Apologies. Yes, I'm back into French. Sorry about that. So let's talk about the exposure of Arm 3 in the combined approach. We notice that the adoption of family planning has increased in the group which received the support from Pathfinder. So from 3 to 8%, even though the current rate has decreased where the support was stopped. And those are significant results. Next slide. So to summarize, in villages randomly assigned, but not to receive additional Pathfinder assistance, most of adolescents and many husbands continue to receive RMA activities. In villages randomly selected to receive additional support from the midline survey to the final survey, there was no significant increase of the current family planning use. In Arm 1, the current family planning use slightly decreased to 18%. In Arm 2, the current family planning use decreased from 11 to 8%, decreased by 11 to 8%. In Arm 3, from 23 to 28%.
Parlons maintenant de la rentabilité en termes de l'approche qui a été la moins coûteuse. À mi-parcours, le bras 1 de visite à domicile était l'approche la plus rentable, car le bras 3 de l'approche combinée était légèrement plus cher.
Arm 3 approach cost a little more
L'approche des
than Arm 1,
petites était 2 fois plus chère.
and Arm 2 was in between. During the final survey, the most economical approach was Arm 2 approach, small group discussion. Among the groups continuing to support, to receive support for RMA, the results were fairly comparable in all three. Arm 1 and Arm 3 were cost a little bit than Arm 2. But with the group who did not receive support from Pathfinder for RMA, Arm 2 was also the most economical. Arm 1 was too expensive. Arm 3 was as expensive as Arm 2. Next slide.
L'utilisation actuelle de la PF entre les groupes pour recevoir la plus faible.
The use of family planning shows not significant differences between the minimum use of minimum dose or maximum dose. What are the other effects caused by RMA intervention beyond the current use of family planning? Regarding violence, domestic violence, Arm 2, group session, and Arm 3 combined approach led to a reduction of domestic violence. Regarding the perception of adolescents, certain acceptance by community of use of family planning, Arm 1 and Arm 3 showed an improvement of this perception. Concerning now the perception by support of the community for gender equity and equality, you see that the Arm 1 approach with home visit was less likely to cause an improvement. And regarding the perception of husbands about the support of community for gender equality, it is mostly the group discussion approach of Arm 2, which is more likely to improve this perception. Same thing about the attitude of husband about gender equality. To summarize, the small discussion group to reduce the probability of domestic violence. This is what it showed last year, based on reports from wives on Arm 2 and Arm 3. Home visits seem to increase acceptance by adolescent wives of PF use in the community, but in the absence of discussion group, home visits seem to have a negative effect on the perception of both husbands and wife about the support of community regarding gender equality and the attitude of husband in this respect. But small group discussion without home visits seem to improve both the perception of the support of the community by husbands regarding gender equality and the attitude of husband concerning gender equality. At the end of this research, the RMA model recommends to use a combined approach with home visits and small group discussions. And this model shows that it is best to use community dialogue as an additional component to promote dialogue. But we saw that in terms of exposure, it is not necessary to go up all the way to 12 visits, home visit, or 12 small group visit to promote change. We noticed after 4 home visits and 4 small group discussions, and community dialogue, it is enough to generate a behavior attitude change of adolescents concerning the use of family planning products. So these interventions, which are proposed by this model, can be broken down like this, by taking into account the role of husband. For adolescents, the model is designed to work on along 5 quarters. 1 quarter for startup activities and 4 quarters where will be an alternance of home visits, small group discussions, and community dialogue within the same quarter. So at the end of the year, married adolescents will have been totally exposed to the package of interventions. For the husbands, who may be absent for long periods, the program includes maximum intervention during 2 quarters when they are present in the house, and the husband can also follow this program when they come back to complete the package of intervention they received earlier. So this process took place in the intervention area of the with the Gates Foundation support and the support of USAID in Niger. And it started in 4 regions, which are indicated in a map that you see here in purple, especially Zinder, with 36 sites and 72 relays for the RMA approach, the Tawa and Dosso at 36 sites and 72 relays, so both regions, but the Tilbury at 60 sites and 120 relays, community relays. And this process started in July 2022 and will go on until August of 2022. So the implementation of the model starts with startup activities. These activities start like this. First, identification of integrated health center, and this identification is based on performance in terms of family planning of the center, and also we identify target villages based on the population size, the absence of family partners, and also availability of health services. These services with CSI, so health centers, integrated health centers. And that the identification of community relays based on volunteer work and availability. It must be people who live in the village, are aged between 20 or 30, are married, and good morality. And the process continues with recruitment of beneficiaries, the adolescents between 13 and 19 years old, married and live with the husband, and with the agreement of the husband to take part of this model. And there's a strengthening of community stakeholders, especially training of trainers, training of relays, and equipment of relays and community facilitators. Next slide. Intervention of the model. We have seen them. It is mostly home visits, discussion with small groups, and community dialogue. And a follow-up or monitoring mechanism was implemented through meetings every 2 months and in each health centers. We also have a monthly supervision of community agent by the person in charge of the CSI, and organization of supervision and monitoring joint meeting every 6 months by various agents with the control of the health ministries. And
so it is key to reinforce the service offering in health centers to meet the demand. Next slide. So all the tools were reviewed to adapt to the model. So the curriculum were reviewed, everything was reviewed, the training curriculum for male and female, the facilitation guide was reviewed as well, but also the tools that were used. Next slide. So in all three regions, 336 community relays were recruited to perform the model. So we're talking about 168 men, 168 women. They were trained to use the tool, and that enabled over 38,000 home visits, which reached over 7,500 couples and facilitated over 8,700 small group discussions. Next slide. So here are some of the results, qualitative results, that show the implementation of the model with testimonies. So we can start with the village chief from Tawa, which says, I assure you, before the village, there were many births that were very close to one another, and the mothers and the children suffer from all kinds of diseases, and even the husbands found themselves in difficulties related to the expenses due to the purchase of drugs as well, and they were worried for the health of their families, and they ended up asking money wherever they could. Then after the work of those relays, more time passed, the more the problem of close pregnancies became the story of the past, which is no small thing to help our village. Another village chief from Zinder said, now it is more important, this is more important than receiving goods, and especially the products for birth spacing are being given for free. And there are all kinds of products in each year and in all those years that you want. So if that's the way it's going to evolve in our village, there will be a significant progress. Our wish is that things continue that way and that the project increases in the whole region of Zinder. So this shows the positive of those interventions. And another chief said, in all the localities where we travel, we have also become relays, and we take time to explain to the people the importance of spacing births. People now wait for the last child to grow up before we move on to having another child. Before, there was not even life. And if the wife would die, the husband, the kids would die, and even would die because everybody is exhausted and nobody rests. So this model really came to help populations. Next slide. So what are the potential challenges that need to be considered in the implementation of this RMA model? Let's start with the community level. Let's think first about the seasonal migration of husbands. If they are not present, they will not benefit from this model. So those need to be adjusted so that the husbands can benefit from those interventions when they are around. And the second challenge is the commitment and motivation of those community relays, because it is volunteer based, but they need to be motivated to continue to hold on and to be more committed and engaged in those interventions. On the institutional level, the challenges are mostly the availability of trained providers on adolescent-friendly health and reproductive health services, especially with the migration of the population. A trained provider needs to be flexible because they might be affected to a different site, and that creates some challenges. So obviously the availability is one key issue. There's got to be the availability of CSI leaders and for the implementation, monitoring, and community dialogues. Those need to be taken into account. Next slide. So ladies and gentlemen, that was my presentation. This is what I wanted to share with you in terms of training on the RMA action, which led to the current model and which is being now scaled up on the national level. I thank you very much for your attention, and I am available to answer any of the questions you may have. Thank you, Akim. Thank you so much for this great presentation. It was very clear, and I hope that it will bring comments and reflections to you. I think you followed with great interest what was just shared with you. Mr. Akim shared greatly this experience, which is integrated to the Impact 2 project, in which was involved in his research phase in those 3 districts, Loga, Doutchi, and Dosso, and to highlight the methods and also the intervention package on family visits, the little small group discussions, and community dialogues. Those health packages constitute those arms that were explained, and which led to the different phases of the research and showed a significant results. What we can remember now are 3 main key questions. I think we're having connectivity issues. I can't hear the speaker. The interpreter cannot hear the speaker anymore. So we have little connectivity issues. I think we're going to cut short the comments. Let's move now on to the questions and answer. Anna, are there any questions? So we do not have any questions right now in the chat. So, but since we have a small group, so we're going to let somebody speak. So sorry for the one Drogo. I think you can have the floor if you'd like to. Yes, please, let's give them the floor if they want to. So who is the first person who would like to intervene? Sekou Omar Ouedraogo. and he is still on mute, so I'm not sure, but that he has his hand raised. So go ahead. Thank you very much. Oh, so that was an error. So I don't know if there's another hand that was raised. So there's a question in the chat. So the health ministry is using the RMA as good practice. What is being done to scale up this great practice? And this is a question from Asma Yarogali. Monsieur Akim, this is the question from Dr. Asama with regards to the scaling up of this wonderful intervention, which was accepted by the Ministry of Health as a good practice. Do you have elements of answer? Yes. Thank you so much. And thank you, Dr. Asma, for this question. I think it was recognized as good practice by the Ministry of Health. And it's already become as part of the institution. We've already started the scaling up in the 4 regions that were mentioned in the presentation. So other partners are implementing the RMA model in different regions, such as Save the Children, for example, in the Tillabéri region. And I know that in 2020, the Direction of Family Planning wanted to duplicate the model in the Niamey and the Kifa region. So currently, we are finalizing and validating the RMA model. And this model will be one of those health path packages, and which will be adopted by the Ministry of Health with all the tools that we have talked about. The elaboration and validation process also happened with family planning and the tools that were used to validate the model. So this workshop will help to draw some conclusions and will be leveraged to validate and finalize an intervention that will be scaled up. So this is what I can say about what is being done for scaling up this model. This is also part of the Impact 2 approaches. And those will be documented by the DEP as good practice. Akim, thank you so much for this answer. Are there other questions? So somebody had a little connecting issues. So can you come back to the adolescent strategy? I'm not sure we have 1 minute to go over that. If you can come back to the strategy.
Yes, to summarize the model, the RM intervention, there are 3 components: home visits, which are organized to see adolescents, small group discussions, which are organized in safe spots, facilitated by community relays, and also community dialogues organized in the village, on the central square of the village, in order to create a facilitating environment to promote the use of services by married adolescents with the support of their husbands. So it is the whole of this package, which the RMA model, which is intended for married adolescents, but there are also interventions targeting the husbands to change his attitude or behavior. And so the husbands is also present during home visits or small group discussions in order to change the norms and promote better support from the husband for their spouse. And so this aim to change sexist standards and also to reduce gender-based violence. This is what I wanted to say to summarize the RMA approach. Thank you, Akim. We have a last question coming from Shabitak. Thank you for this beautiful presentation. It was interesting to see the results that show the impact of small group discussions about norms and better than home visit to reduce gender violence, gender-based violence. Do you have any ideas about the reason why this small group discussion work better than home visits? Okay, so regarding the change of standards about gender and gender-based violence, it is mostly the small group discussion that worked because in general, husbands commit violence on teenagers that are not major violence. They consider it normal. But this type of violence should not take place within a couple. And so in this kind of situation, when husbands are in a support group together, they all share their experience about their relation within the couple, and the facilitator or the mentor manages to use this experience, this sharing of experiences, to raise awareness about what kind of behavior should not take place and to promote violence-free relations within a couple. And this is what explains also the fact that discussion in small groups are more effective. They enable change of behaviors and more than just a home visit. They are more effective, reduce gender-based violence than just home visit. Also, for adolescents, when the visit takes place, the adolescent can share her experience with the person who comes to visit, but she cannot know if other teenagers from the village are in the same situation. And when she goes to a support group, she can share her experience with other women or other girls exposed to the same situation. So the beginning of a solution, it's an improvement for them in order to help them improve this situation within the couple. And the community relays are also very helpful for that and try to strengthen this behavior change and help married adolescents to talk to their husbands and discuss a change of behavior and enable a more harmonious life, married life. This is what I want to say as a comment about the role of small group discussion to change standards in a community. Are there other questions? Can we conclude? No, there are no other questions. But if, can you hear me? You can, oh, you see the email of Akim on the screen, so you can send him questions to his email after the end of this session. Much. Anna, I think that before concluding this exchange, I would like to strengthen what Akim said in the answers to the relevant questions that were asked. And it is important to talk about replication or scaling up this initiative, reaching married adolescents. I think Akim already said it, his presentation, but the ministry was involved and provided support in all the processes that took place from inception and research to the extension phase, with the revisions that took place and identification of the model to implement, but also the use of tools and scaling up to the expansion phase in these 3 regions. So I think it is important to say that for us in a ministry, we consider it as our strategy, our activity, where I assume responsibility for it. And it was included in a national action plan that was mentioned. And this intervention with high impact will be developed and promoted. Now, as it was requested, also we have to make sure that all the conditions are met. And what I mean, resources, material resources, financial resources, in order to scale up the model. But this extension requires that the stakeholders become more involved, but also it is important that other partners for implementations consider that they own this project also, because it is important to provide access to services of family planning to young people and adolescents. It is a problem, but it is a priority for our ministry, and it is part of our family planning policy. And in this respect, I want to say that we are making sure that we identify a shortage of product and services. And this is related to our action plan. And I think that this is connected to the high impact interventions and the model to reach adolescents, provide resources. So I will ask all stakeholders to support the health ministry to scale up this policy in other regions, especially isolated areas which are affected by a number of problems and lack of security. But we have to really be active in those regions, make sure that we apply there to provide what I wanted to add. So I will conclude by thanking the Pathfinder NGO for its initiative. It has to be said again and again, because they have been playing a major part in the implementation of this initiative in the 3 regions that were mentioned. And also, I want to thank them for their support, working along with the ministry to reach our goals on a national level. I would like to thank Akim and all the team working with us for this beautiful experience of sharing of experiences. And thank you, Akim. And I think that we will be back with you in other places. Thank you very much, Dr. Osseni. Thank you, ladies and gentlemen. The connection is not good, but thank you. We will, inshallah, meet again at the same time next week for another workshop of sharing of experience. Thank you and see you then. Thank you, Doctor, and have a good day.